Welcome, everybody. I'm Paolo Cassano. Today is June 16, 2023. Welcome to the MGH brain-PBM clinic rounds. It is my great pleasure to introduce Dr. Dan Iosifescu, professor in psychiatry at New York University and director of clinical research division at Nathan Kline Institute. Welcome, Dan, and please take it away.
Thank you, Paolo, and it's my real pleasure to be talking to all of you. Let me just try to see if I can share my slides. So can everybody see my slides?
We can.
Okay, great. So I wanted to review some information about from a recent study that Paolo and I have done in Boston and in New York, Nathan Kline kind of jointly. And that's kind of the most novel information with respect to the difference in simulation parameters leading to differences in biological and clinical effects in patients with major depressive disorder. But if you allow me, I will just go and also give you some background information from some of your studies that I realize that this is a very photobiomodulation savvy group, but you may not necessarily be privy to all this other information. So this is my disclosure, and it's really very prevalent. Depression is by far the most significant source of disability, and actually by WHO standards, even the second source of worldwide disability, even including medical disorders. And our current treatments are relatively insufficient, and the neuromodulation treatments that are currently approved are logistically not ideal by virtue of requiring all these in-office visits. Now, the story of mitochondrial dysfunction in depression actually is quite interesting. This is a synopsis of all the interrelations between mitochondrial dysfunction and inflammation, oxidative stress, and neurogenesis. And in fact, there's a series of studies done primarily in animal models of depression, suggesting that at the cellular level, both resilience and healing from chronic stress disorders, including depression, including chronic pain, including post-traumatic stress disorder, etc., essentially is based on neuroplastic phenomena, that there would be a dramatic increase in dendritic buttons and in new synapses that would correlate with this healing and eventually improvement. And that actually happens with a variety of treatments, including the most novel and exciting treatments that we have, like psychedelics and ketamine, and all these things actually essentially come to this final common pathway of just that the difference between them is how fast does this phenomenon happen, but it's really what needs to happen for people to get better. So the question is, what are the impediments? And one of the impediments has to do with the fact that all this neuroplastic work has to do with building membranes. There's a lot of construction, quote unquote, and that actually is very energy intensive. And it may well be that even a system that seems to be working relatively normally from a bioenergetic perspective at baseline is not able to put up with the extraordinarily high demands of these neuroplastic events. Now, there is a way to actually study this in vivo. We can study it, as I mentioned, with electron microscopy, but that would require pathological specimens and biopsies, and it can be done mostly in animals. The phosphorus spectroscopy, so this is magnetic resonance spectroscopy tuned to the frequency of the phosphorus 31, essentially allows us to study in vivo brain specimens compounds like beta NTP, which is in the brain mostly ATP and phosphocreatine and inorganic phosphate, and a series of phosphor-rich lipids like monoesters and diesters, and essentially get a very good understanding of the equilibrium of the bioenergetic metabolism, which is essentially mitochondrial functioning. And there were studies that have been done over the past 2 decades suggesting that patients with depression actually have deficits in ATP levels. And in a study that our group has published more recently, we were showing that this is actually specific to the gray matter, and that there's decreased levels of ATP and actually increased levels of phosphocreatine, which is the long-term storage of energy-rich phosphorus molecules. So it's as if the energy is not really used as much. And also that when we are actually treating successfully people with depression, we can see a change of this equilibrium. So this is looking at baseline comparison between controls and responders and non-responders, and looking at the fact that phosphocreatine tends to be much higher in people with depression, but also that it's somewhat predictive of who's going to eventually get better. And that those, even with the exact same treatment, the people who actually get better with treatment have this renormalization where the ATP levels increase and the phosphocreatine levels decrease, and that's not happening in the non-responders. So a lot of reasons why it would make sense to try to improve on mitochondrial energy metabolism in the brain if we can. And the question was, how can we do that? And our first attempts, I was still at Mass General at that point, and we were looking at a bunch of these natural remedies that seem to have some mitochondrial modulatory effects. We wrote this review paper. They do a little bit, but they're really not effective to the extent that we would have wanted to. So it was fortunate to actually start learning about the effects of photobiomodulation as a technique that uses the near-infrared spectrum to affect mitochondria in living tissue, and even more, I mean, it can even penetrate to the brain. I'm not going to belabor this part because this is a group that knows or even has generated some of this information. So it's really exciting, the cytochrome C oxidase that we think might be associated with the mitochondrial energy metabolism enhancements, that we have good data to suggest that even transcranial administration of this near-infrared light could actually affect significantly the cortex, although it does matter how thick are the extracerebral tissues and how old are the participants. But ultimately, there's a reasonable expectation that one can affect tissue that is immediately in the area irradiated by the near-infrared light at certain frequencies and at certain energy intensities. These are studies that were done by our colleagues in Texas, showing that there are clear changes in cellular oxygenation, looking at differences between hemoglobin and oxidated hemoglobin, and that cytochrome C oxidase is also in play. I went more quickly over that information just because I'm assuming that most of you have already seen it. This is something that you may not have seen, which was our own original kind of preliminary data that led us to the study that we are currently presenting. So this was a data set collected in 20 healthy volunteers. They just received a photobiomodulation session inside the MRI scanner at 320 milliwatts per square centimeter, one-sided. And the outcome was based on the changes in the bold signal, as a marker of both changes in blood flow and in changes in oxygenated versus deoxygenated hemoglobin. And there were really remarkably strong changes that happened primarily when you compared the bold signal, the blood flow prior to the onset of the laser, and then averaging the bold signal during the laser stimulation. So it has this kind of ridiculously large effect size of 1.5, but it was very robust and enough for us to try to use this as a biological method, as a proof of target engagement, to essentially test multiple doses of the photobiomodulation and try to see, what type of parameters would be most helpful here. I mean, I'm going to quickly remind you that there were a series of small but very exciting studies that have been done. Fred Schiffer had published one nearly 14, 15 years ago, an open label study that suggested effects could last even more than 2 weeks after a single session. And then there were 2 studies that Paolo had done at Mass General, and I was pleased to advise him and collaborate with him during those studies. The first one, very few patients with very high irradiance, 700 milliwatts per square centimeter, and showing robust effects after multiple sessions. And what's interesting about this high irradiance is that it really is primarily tolerated when you use some skin cooling effects. And that was one of our problems in the new study, where we tried to use it again, but we weren't able to. I'll get to that in a moment. So even in a few patients, the effect size pre and post was really robust, 1.4. And then this was the second study with lower irradiance, but large surface of photobiomodulation exposure. And there was a clear separation between active and sham after 8 weeks. The third study, which we did in parallel in Boston and in New York, had also low irradiance, but much lower energy. Unfortunately, some of the sites, the photobiomodulation sites, the ones that are presented here at the top, were actually mostly covered by hair in most participants. So actually the effective energy available was significantly lower than what we initially were hoping for. And in that study, the effects, we published this last year, the effects were actually not very different from sham. So very discordant effects. There are some other studies. I just took advantage of reminding you of our own data. But the point is, in depression and in other fields in general, there's really not a very good understanding of what are the optimal parameters for photobiomodulation to elicit the best outcomes. And that this is a real important question that we as a field will need to answer. And maybe the study that I will just show you brings us closer to having such an answer. So these are the specific aims of the study that we're doing. So this is a two-part study. The NIH and NIMH actually love to fund these experimental medicine studies in two parts, where the first part is primarily about proof of target engagement, and then the second part would be about using what's considered to be the optimal parameters, the optimal dose, in a small pilot study. So the first part of the study, the one that we completed, and I'm going to show you the results of, essentially consisted of enrolling patients with major depressive disorder and bringing them to our respective sites to get 4 administrations of photobiomodulation or sham. So this was, there were 3 active doses of the photobiomodulation, and one time they would just get sham. And this was randomized, so people would get, each participant would get a different sequence of the photobiomodulation versus sham order. The randomization was primarily because we were trying to avoid kind of missing patients at one dose consistently. We didn't really think that they would be able to fake their blood flow results. So when we initially designed the grant, we wanted to compare high irradiance of 700 milliwatts per square with medium irradiance of 300 milliwatts per square and a low irradiance of 50 milliwatts per square. And I'll get in a minute to what we actually did. And then the point was, if we get one of these, at least one of these doses to be very well tolerated and to be associated with change in the blood flow, in the bold signal of at least a 0.5 effect size, so that's a moderate effect size, then we would take that optimal dose and test it in a repeated dose study. So these were the actual 3 quote-unquote doses that we ended up with. And as you can see, the high dose that we originally wanted to be a continuous wave dose of 700 milliwatts per square centimeter wasn't that. Why not? Well, we tried it on participants, and out of the first 7, essentially 6 weren't able to tolerate it. We had made a protocol where they would get a test dose before we start randomizing them. So that didn't lead to us losing participants. And since we said that tolerability was going to be one of the reasons why we would allow a selection of doses, we decided that that was good enough, and we moved to a pulse wave dose where the peak was still very high, 833, but it was a 33% duty cycle. So you were having an average irradiance of 278 and going from 833, a third of the cycle, and 0, the other 2/3. The other two doses were the mid dose, which was 292 milliwatts per square, very close to the 300, and then the third, which was 41.7. As you can see in the lower row, the total energy was also very different. It was relatively higher, 4.0 kilojoules total for the high dose, and then 2.3 for the mid irradiance dose, and 1.2 for the lower dose. So essentially, these were the doses that we actually compared. Why was Paolo able to do a 700 milliwatts per square centimeter dose in the original ELATED 1 study? Well, it's because as I said, he was using skin cooling devices. We needed to do this inside the MRI scanner. Everything that we could use for skin cooling was not MR compatible. And because of that, we ended up not being able to do it. So those were the doses. Any questions before I start talking about the results? Okay. So when we were trying to figure out, well, which area should we define our target engagement at, we did these simulations, and it was really clear that the area with the type of device that was primarily focused on the F3 and F4 electrodes in the 1020 standard EEG montage, we would probably have the highest amount of irradiation in the middle frontal gyrus bilateral, and that was defined as our primary area of simulation. We also calculated what would be the entire area of the prefrontal cortex that would be irradiated by the laser, even at lower intensities. But what I'm telling you now is that we very surprisingly saw robust results that were also in areas that were not directly irradiated by the laser. So these are the bold signal changes with each of the 4 treatments. So sham, as you can see, there's not much change. With the low irradiance, there's actually a decrease in bold, contrary to what we were expecting. With the medium irradiance, there's a robust increase in bold. And with the highest one, the pulse wave, it's essentially not distinguishable from sham. This is averaging the bold signal through the entire cortex. So most of it being areas that are not being irradiated by the laser. And that was really very surprising to us when we actually started doing paired analyses to kind of just look at each of these areas. There's in the atlas that we were using 150 areas of cortical surface that were defined. About 139 of them were statistically significant in terms of changes with the medium dose. So it was really clear that it was not an effect driven by just the frontal areas, but if you are looking at the frontal areas, the effect is the same, not necessarily larger. So this is the entire frontal area illuminated. And this is a different way of looking at the same effect. It's a density plot of the bold changes. So as you can see, the 0 means no change. Sham is nearly clearly on 0. The high dose, which is so sham is the darker blue, the lighter blue is the high dose, and it's essentially there at 0. And then you have a very significant change towards the decrease with the low dose, and the very significant change towards increase in bold with the medium dose. And this is what's happening if we just look at that middle frontal gyrus, the area that we decided was going to get the maximum amount of photobiomodulation radiation. Again, we're seeing the exact same pattern where low dose is associated with a decrease, medium dose with an increase, and high dose and sham show close to nothing. And if you wanted the actual numbers, so these are Cohen-D effect sizes. Essentially, I'm showing you the 3 analyses for the total cortex, for the entire areas of the frontal cortex that see any of the laser light, and then for the medial frontal gyrus, which is actually seeing most of the laser light. And as you can see, it's really not that different. We're seeing a robust increase in bold with the 300 milliwatts per square centimeter dose, and a significant decrease in bold with the 50 milliwatts per square centimeter irradiance, and no effects with the pulse dose or sham. Now, when we're looking at the effects on depression, we need to start by saying that this is not optimal. After all the studies that we've done in depression with photobiomodulation, we really don't think that the effects are going to be robust after a single administration. So this study was not, this first part of the study was optimized for looking at the effects on the biological outcomes, but not necessarily on the clinical outcomes. And also the a study like this, which is essentially a crossover study, is going to be dependent on what's happening week by week. So obviously, if someone is getting a very helpful treatment in the first few weeks, then they would have less room to improve in the next few ones. So Dr. Terrell, who's our statistician and who did this analysis, was very correctly trying to get a way to present both the week by week and the dose by dose effects. As you can see, there's a clear improvement that happens with both the medium and the low doses. And they actually even get to be statistically significant at week 3 in a omnibus statistical analysis. But as you can see, the red squares are the medium dose, and the gray squares are the boxes, not squares, are the low dose. They tend to be the ones showing the most significant amount of decrease, which is improvement. Now, if we do an analysis where we ignore the week by week effects, which is, as Dr. Terrell is going to remind us, not quite correct, because these effects do depend on what's happening the week before. But if we just ignore them, again, we see the same situation where the low and the medium dose, the ones that were most biologically active, although they were active in completely different direction. I remind you, the medium dose was increasing the bold signal, the low dose was decreasing the bold signal, but they are the ones associated with the most significant clinical effects, whereas the quote unquote high dose, the pulse dose, and the sham don't really show anything in terms of clinical effects. This is so the total burden of the side effects was measured with an instrument called SAFTI. It's a very standard instrument for use in clinical trials, and it essentially captures the side effects on many different organ systems. And this is just looking at the aggregate total burden of side effects. Not surprisingly, the most common side effect was kind of warming of the skin at the locally, that was completely gone after the end of the stimulation. But as you can see, the total burden of side effects actually decreases from baseline. It may also be related to the anxiety of participants before starting the treatment and later on. But it does make a very strong point that there's really no significant side effects that we need to worry about. And Dr. Cassano is currently writing a much more detailed report of all these different side effects, broken down by organ systems. And the same data just plotted differently, showing that indeed the total burden of side effects is much lower with most of the active. In fact, of all the treatments, the sham has numerically a higher burden of side effects than all the active treatments. So that was our first study, the dose finding study, where because we said that our proof of target engagement was going to be an increase in the bold signal of at least 0.5 effect size Cohen Z and a very tolerable dose. So that seems to be our middle dose, the 300 milliwatts per square centimeter continuous wave dose, which we're going to now take into an 8-week repeated dose study with 2 administrations per week. Again, a study that is just starting right now in parallel at Mass General with Dr. Cassano and at NYU and Nathan Klein in New York. And if you're curious, these are the helmets that we're using. These are modified light cure devices that our collaborator Luis de Taboada has adjusted to fit the parameters that we're trying to use in our study. You see our research coordinators kind of proudly wearing them. So in conclusion, this is there's a clear information about mitochondrial dysfunction in depression having important implications for resilience and for healing. There's a good potential for transcranial photobiomodulation to modulate mitochondria and improve clinical symptoms in depression. And what's really new is that we have now good data to prove that specific parameters of photobiomodulation have very distinct, even discordant effects on both blood flow and on clinical symptoms, and that we can't really have a one-size-fits-all type of approach to these treatments. So I'm going to stop, but not before actually highlighting the large number of collaborators at all these institutions. We have, besides NYU, Nathan Klein, Mass General, they have collaborator at City University of New York, and Luis de Taboada at LightCure. Thank you so much. I'm going to stop sharing and be happy to consider any questions.
Thank you so much, Dan. I mean, I was quite impressed with all the presentation and the overarching presentation of the data and all the new tables and pictures and all of that. It's a compelling story. Of course, I guess the question I have is in general, again, what do we make, as you have stressed, of two radically different, or what seems radically different mechanisms and doses that produce both an antidepressant effect? I guess that's really what I'm wrestling with. I don't know if you or anyone else wants to comment on that.
I mean, one of the reasons why we saw this discrepancy between the 50 milliwatts and the 300 milliwatts dose with respect to the bold signal may have to do with the fact that while we were trying to get a measure of blood flow, bold signal is actually a sum of two different components, one being the blood flow and the other one being the changes between oxygenated and deoxygenated hemoglobin. And it may well be that these effects, these two parameters don't always go in parallel, and that in the lower irradiance case, we actually saw more of an effect of change. So you can have less of an effect on increasing blood flow and more of an effect or remaining equal effect in terms of changes to deoxygenated hemoglobin. So it's still biologically active, but with some lesser effect on the blood flow that results in a net decrease of the total signal. We have some information in terms of we collected data that is multi-echo, and the three echoes are so there are three measurements of the bold signal at the different time intensities, and that may give us a sense of kind of a little bit of additional data on the separation between blood flow and oxygenated hemoglobin. But it's not perfect, and we're still going to be left with some hand waving at the end of this exercise. But I actually think it's very interesting. And the other thing that is actually very interesting is that the effect is generalized. I mean, we don't see, we were expecting to see it in the area most immediately illuminated by the laser, and we are seeing it in the entire cerebral cortex. And that to me is absolutely fantastic. It may also actually, I think it has a very direct implication, as long as this is true and we believe it. And Paulo, you were telling me that there's another group in Canada that has somewhat similar results. Or actually, this is something very important, because one of our problems when we use photobiomodulation is that we have certain areas like the prefrontal areas that are easier to stimulate, and to do this in other areas of the head may require shaving small portions of people's heads, or even more than small portions, and that may be not easy to perform. So if we actually can robustly demonstrate that these effects are generalizable, it's actually extraordinarily important. I'm now involved with a study that is trying to do something like this in traumatic brain injury. There, the actual lesions are very different from person to person, and the main question is, do you really need to have a personalized approach where you irradiate just where those lesions are, which actually makes to a horribly messy study design, although it may make sense for the actual clinical problem. But if we can actually argue that we have effects with a standard way of administering the laser, that may actually make the problem much easier. So I think, to me, that's a very important unexpected result.
Thank you. And I just wanted to open up. I see Lou, he's raising his hand.
So the other group in Canada doing a similar kind of work is our group working with Baycrest Hospital. And I find this very interesting because I think our findings are pretty much aligned. Now, we look at BOLD, you look at BOLD, and a lot of people make assumption BOLD is, the oxygenated hemoglobin in the blood to be equated to cerebral blood flow. We found that actually they're different. What is interesting is we found that certain parameters, without going into too much detail, we didn't see as much BOLD signaling, but we saw a lot of CBF, cerebral blood flow. So there is, you're right in differentiation.
I'm sorry, measured with what? The CBF?
fMRI.
I'm sorry.
You
can have ASL, arteriosplenic labeling, that gives you a different, but with fMRI, it will still be through BOLD that you would measure blood flow.
Yeah, I'm not familiar with the details, but we actually reviewed the data recently, and when we measured, I think it's good that do groups have communication as well. This is very interesting. Now, what you found, actually, there's inverse response between the BOLD signal and the clinical outcomes, right? It seems like...
Well, what we found was there were two doses that were biologically active, although the signal was going in opposite directions. And those biologically active doses were also clinically active. We have all these concerns that you're also highlighting about what exactly does BOLD mean, and can we accept a decrease? So I'm not writing off the lower dose. I'm just saying that
this is actually quite interesting, because the dose actually is also dependent on dose, and time and everything, even the wavelength of what we see. But what we are theorizing is you're noticing perhaps a lower level of oxygenated hemoglobin because the oxygen is being used in the mitochondria to process in the mitochondria for oxygen phosphorylation. So then you get the outcome. So that's, I think it's because the mitochondria is using the oxygen. So the hemoglobin has deposited the oxygen into the mitochondria, and you get the physiological positive outcome. In your case, it's depression, and that's why it's actually higher level of oxygen in the blood doesn't mean it's or lower level is not necessarily a bad thing, because it might be mitochondria is processing the oxygen. So you have a lower level left in the blood circulation.
Right.
Now, I'm saying that because when we, so I don't know all the techniques in the fMRI because I'm not that technical in fMRI, but while we see a lower level of BOLD, and this is the work done at Baycrest, but we still see a high level of CBF. It seems to be anomaly, but it's not, because the high level of CBF doesn't mean you have the same level of oxygen in the blood. Now, don't ask me about the detailed measurement, because I don't know, but I'm
okay.
the outcomes here.
I would be interested in the details, but in general, I think
Yeah.
it's considered.
Right. Okay, you lost for a while.
Yeah, I don't know if that froze, but I saw also there were two more questions, one from Jeff.
Can you
and
see me
one...
now?
Yes, we can, yes. One from Jeff and one from Diane. So if you guys want to go ahead and ask your question.
Okay. Well, first of all, I think this is a very interesting study, and I agree with your comment that says this is something that needs to be done, because these parametric questions get asked all the time by reviewers who are looking at studies that are submitted for publication and also for grant reviewers. And, you know, their job is to just ask questions and we have to respond to it. And it would be nice to have things that we can refer to, studies that said, you know, this has been investigated. So this is for depression. It'd be interesting to see if it also replicated for other conditions. And my other question about this was, you have the distribution of subject responses to the different dosage, which is great because it talks about the individual differences, and we see those individual differences. And it seems to me that digging into that would inform case decisions for treatment as well. I know you're looking to see about sort of overall population reactions to this, but you know, the individual differences may be important. I mean, one of the things that I thought about looking at it is these data almost suggest like the Goldilocks and the Three Bears effect. It's like it's too hot just right, or too cold. And there's a window that seems to be an optimal treatment window in terms of, you know, the dosage, which might be the case, you know, and Mike Hamlin has talked about some of this, you know, years ago in terms of, you know, how much you want to irradiate. And I think that studies like this are really important to do. And even like individual case studies looking at some of these effects, I think would kind of accumulate and give us a picture of what's happening. I would like to have that kind of information available, because it always seems, going back to reviewers, you know, they want something to make them feel comfortable in accepting what those data are.
I agree, and I'm not sure that our data are sufficient to really make that statement that there's a kind of, but very many treatments have this kind of inverted U-shaped curve in terms of efficacy, where you have a sweet spot and then too much or too little are equally not good. So I would not be surprised if that were the case here also. Well, but I'm not sure we have enough data to really forcefully state that.
Well, but it suggests a direction, which I think is a starting point. And, you know, your other point about, you know, that these averaged effects throughout the cortex suggest the possibility that you're saying, well, it doesn't really matter as much what your entry point is, as long as you're providing stimulation and it has some kind of distributed effect, which, you know, has implications for methodology. It has implications for device design and placement of nodes on the head, you know, and if, like, for me, I'd be a perfect candidate with no hair, you can put it anywhere. But a lot of people, you know, it's like, yeah, you're only going to go on the forehead for them. And if that worked just as well, I mean, that would be an important methodological, you know, piece of information.
Thank you both. I see we are almost at the end of time, and I see two hands up. So really 1 minute question and answer. I saw first Fred and then Hamdi.
Okay, I wondered whether using near-infrared spectroscopy would help answer some of the bold questions that you have. And I'll just add again that we saw big differences in that men had greater blood flow responses in women for some reason. And I wanted to just if you could repeat what was the irradiance of your effective dose?
I'm sorry for the background noise. The most effective dose was about 300 milliwatts per square centimeter. And you're right, the near-infrared spectroscopy could add additional detail, but we didn't have it in this data set.
And one of the things, I've done several studies, two that were focused on cravings, but we also measured depression, and we had highly significant effects in people who they were not severely depressed, but they went from like 13 down to 8 after in one session. It was after one dose. They came in twice, and they got 1 week they got sham, 1 week they got active, and what we did was we treated one side. It was unilateral transcranial photobiomodulation, so I published a few papers on that. I'm doing studies in my lab with depression, and finding that with right after one treatment compared to sham, you can get high effects.
Thank you, Fred. Haldi, really quick question.
You're muted, Dr. Liu.
I thought I would not have time to ask, but quick questions. One is that, first of all, it's very helpful, useful presentation. I really appreciate that. The question is, have you published anything? So that's the first quick question. The second quick question is, does hair affect the measurement or the treatment?
So we are in the process of sending this publication where we've just completed this analysis. The study was ended a few months ago, so you're going to see it hopefully published soon. And we were not stimulating over hair, so we learned our lesson from previous related 3 study that I briefly showed, where we got a lot of problems because of some of the sources were over hair. So we in this current device, we are not putting it over hair at all.
Can I do a quick question? Sorry. Did you measure anything post stimulation, which means how long does this effect?
Yes, we did measure. We also measured, I didn't show those results. The effect actually decays very quickly, like in a matter of 2-3 minutes. So we measured a total of 10 minutes post-stimulation, and the averages are only slightly different from the baseline. But if you look at the first 2 minutes, they are still, it's a quick decay from after you turn off the laser. So that's why there were some studies suggesting that there was no difference, but they were measuring effects 20 minutes after stimulation, and you probably don't see anything at that point.
Thank you.
Thank you all, and to be continued. Thank you for being here today. Take care.